Hello, this is John Canelopoulos from a center here in Athens, Greece, the Laser Vision Ambulatory Surgery Center. Let's go and see this young gentleman here that we evaluated today. This is a patient who had LASIK for about -1.5. I'm going to jump to the report. This was in 2018. He's 12 out of 10, so a 20/15 uncorrected visual acuity with the green better than red, and with spectacles of +1/2 in both eyes and 0.25 astigmatism at 22 degrees in the right, he feels he sees much better. His refraction with us is minuscule. The wavefront refraction is +0.18 -0.38 at 121, +0.18 -0.25 at 47. And bizarrely enough, he complains of problems both in bright light and in low light, and better function in intermediate light conditions. Now with his spectacle correction, that little +1/2 and 0.25 astigmatism in his right eye, he is a 20/10 to 28 visual acuity. And we're going to go and study here his contrast sensitivity. This is the contrast sensitivity that he has, and we can see that it's poor in the low spatial frequencies and relatively good in both eyes in the medium, and again poor again, especially in the right eye that drops all the way down here in the high cycles degree frequencies. And this is let me see, I do have his contrast sensitivity with just the +1/2 contact lens that improves drastically. I'm going to pick it up from here and try and show you this as well, because I thought this was remarkable. All right, so here is the contrast sensitivity with a +1/2 soft contact lens. And you can see that both the low cycles per degree as well as the high do improve overall drastically. And we're gonna go and see, this is the without the contact lens, and we're gonna go see what the topo guided fix would be for his right eye. But I jumped the gun a little bit. The right eye wavefront here shows a very minuscule refraction. We can see the refraction ranges in the plus range all the way from almost a +1 diopter to a best red 0.18 with a little bit of astigmatism, and the RMSH is 0.68, so almost 0.7. That is significant, with coma at 0.25, so little coma. The raw data are relatively good. These are the wavefront, the turning wavefronts on the left eye. Kind of similar picture with a +0.26, -0.26 of astigmatism. So we can all agree here that the refraction is minuscule. These are the placido disc images of the left eye. We can see there's significant angle cap on the left eye with a 280 micron angle cap on the x-axis and 220 on the y-axis. And this is the placido disc on the right eye. It almost looks like a repeatedly displaced ablation. A significant angle cap here too, just on the x-axis, 240 microns, almost minuscule on the y-axis. The vertical axis, just 30 microns. The pentacam maps show a little bit of noise centrally here in the refractive sagittal map. Pachymetry does reveal a cornea thinned by LASIK. This was LASIK that he had in 2018. This is the left eye elevation that shows a central ablation, central flattening. To be more correct, the posterior cornea is non-significant, and the right eye, again, a little bit noisy inferiorly. One may say that the right ablation may be, or looks like the elevation change is decentered, the posterior is centered. Thickness maps. And the key thing here, in my opinion, is looking at the epithelial maps. And the epithelial maps here of the left eye show significant remodeling here. We know that this usually shows dryness, although it's not the dry eye epithelial remodeling that we have published extensively in the past related with LASIK, which usually shows a ring just at the edge of the LASIK flap and the curvature change, not centrally. This would be more of a PRK-like epithelial map change or purely dryness, blepharitis. And this is the epithelial map on the other eye, the right eye, again showing this regularity. I took the liberty to put all these three together for the right eye: placido disc imaging, epithelial map with this dry bump here, and the pentacam maps. And there is some correlation in these. So the question is, this patient, and some people would frown upon that he's wearing a +1/2 diopter spectacle and he feels it makes his life easier, but we're here to address the complaint of any patient. And he has a very demanding job as he's an airman. He flies long haul flights several times a week, so that increases the dryness and the demand on his visual performance. So we opted to advise him to treat the external disease first. He does has acne rosacea blepharitis, so we put him in Oracea, which is the new very stomach and duodenum friendly doxycycline that gets absorbed way into the small intestine, 40 milligrams a day. Day after day, antibiotic corticosteroid ointment on the lashes, and topical cyclosporin twice a day for at least 3 months. We'll look at the epithelial maps at a month's time and at 3 months' time. We expect this to improve along with added hydration. And when this improves, then we will revisit the possibility of looking into a topo-guided fix that, as you can see here, again, in relation to the topography maps, we'll try and enlarge the optical zone here, enlarge the optical zone, treat some of this reverse trifoil that we're seeing here. Hopefully, in this map that obviously includes the bias of the epithelial remodeling, treat the astigmatism and the vertical angle kappa, and whatever refractive error we will measure that we will consider more accurate at the time. So again, in summary, this is a young gentleman who is very, very unhappy with his laser vision correction. His Snellen acuity is impeccable, more than average, 20/10, but it has significant symptomatology with glare in bright light and very low light conditions. Again, a very unusual situation where usually we hear these complaints in low light conditions where the pupil dilates. And we will first address the external disease. Hopefully, the epithelial remodeling will improve drastically, and then, in my opinion, if these maps turn all green or more green with less epithelial variability, we would use a topo-guided approach to do a transepithelial PRK with the residual refractive error, and hopefully help this gentleman in having better quality of life and better quality of vision. So I hope you found this complex presentation that evolves many of the modern cornea diagnostics and trying to address the symptomology of this patient. Thanks so much for your attention. This is John Kanellopoulos from our center here in Athens, Greece, signing out.